The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening. Warm welcome to today's ISQua webinar on finding patients before they crash, the next major opportunity to improve patient safety. This webinar provides you with a better understanding of the role of rapid response system and the evidence describing their shortcomings, as well as emphasizing the importance of continuous, accurate monitoring of vital signs for all hospitalized patients. We're delighted to welcome back our today's presenter, E.L. Zimlichman, who is currently a Deputy General Director and Chief Quality Officer at Sheba Medical Center, Israel's largest hospital. Dr. E.L. Zimlichman is an internal medicine physician, a healthcare executive, and a researcher focused on healthcare quality and value measurement and improvement, patient safety, and health information technology. Dr. Zimlichman served as a lead researcher at Partners Healthcare Clinical Affairs Department in Boston, where he worked on a strategic care redesign initiative. For the past 4 years, Dr. Zimlichman has conducted research on implementing technology to improve health care quality and patient safety, and on health-associated infection at Brigham and Women's Hospital at Harvard Medical School Affiliated Center for Patient Safety Research and Practice. Dr. Zimlichman has served on several expert panels commissioned by U.S. Department of Health and Human Services and the Ministry of Health in Israel, all centering around quality measurement and use of health information technology. Just to remind you that today's presentation will take approximately 45 minutes, and we will leave the remainder of the time for any questions that you may have. We might need to stop at the middle of the session to take some questions if there are any at that time. Please type your questions into the chat or question box provided, and they will be posed to Dr. Zimlichman at the end of his session. Please note that we will be using polls during the session and would really appreciate your active engagement. Now, we hope you will enjoy the presentation, and over to you, Dr. Zimlichman.
Thank you very much, Juliana, and I'm happy to have this opportunity again to come back and share with you and the audience what I think is a very important topic for us all in healthcare to deal with. And I think in the next 45 minutes, what I want to try and convince you is that we have a lot of opportunity in this field in preventing what we call preventable mortalities in hospital. It's a big issue. I think we're not doing enough currently. There's more and more evidence and more solutions out there that really merit us to actually look at this closely and take more actions. So I'll start by just disclosing that I'm an advisor to a company called EarlySense, and I'll mention one of their products in this presentation. So this is my disclosures. So before we dive in, I just want to have a quick check of who the audience is, how many clinicians, how many healthcare executives, researchers. So Juliana, if you could initiate the poll.
Thank you, Dr. Zimlichman. Yes, the poll is now launched, and the question stands as follows. Which of the following best describes your current work? The options available are the first one, clinician, nurse, physician, or other. The second, quality and patient safety professional. The third, healthcare executive. Fourth, researcher. And the fifth, vendor. We can see that 50% of our participants have already voted, so we will give it a bit of more time before we display the results. So we have two distinct groups of people here, and we will announce those two groups in a couple of minutes. Okay, so we will give just 10 more seconds before we're closing. We have 80% of the participants that have already voted. Okay, so I'm going to now display the votes. And as you can see, 24% of our participants are clinicians, nurse, physicians, or others. 59 are representing quality and patient safety professionals. 9% healthcare executive, 9% researchers, and we have no vendors. Over to you, Dr. Zimlichman.
Thank you very much. This is very useful, of course, for me to see where I direct this presentation. Let me just get back to my slideshow. Okay, so as we set the stage, we know first of all that patients that are treated in hospitals are more and more complex. We see this every day. Everybody who's in a healthcare environment can see this fact. And still, most are hospitalized in non-ICU settings. We obviously don't have enough ICU beds for every patient that we think needs an ICU. This is, of course, even more so in Europe and the rest of the world, and less so in the US. But even in the US, there is a shortage of ICU beds, and this is something we're going to have to deal with. So we're going to have more and more complex patients stay at non-ICU beds. And we know that 20% of hospitalized patients develop complications. This is research coming from Lucian Lipp back in 1991. 5 to 8% of all patients die in the hospital. The next figure that's important to understand is that an estimated 40%, almost 40%, and in some other research it has been going up to 50% of these events may be preventable. So we're talking about a large number of in-hospital deaths that is preventable, that we could do something about. And I'll show you some of the numbers in a few seconds. And another term we need to talk about is failure to rescue. Failure to rescue is a probability of death after a complication or adverse occurrence. And it is becoming more and more a patient safety issue, where we could have done something to prevent that mortality in the hospital. Now, can we predict clinical deterioration? I think that is the most important question we want to begin with. And there's so many research studies around this going back to the 1980s. I chose 3 here just to quote you. One is this academia study published in 2004 that said that 60% of in-hospital cardiac arrest, death, and emergency unplanned ICU admissions were preceded by hemodynamic antecedents. What are those hemodynamic antecedents? We'll talk about in the next few minutes. Another study published in 1990 has shown that 84% of patients who developed cardiac arrest had instability within the 8-hour window preceding the event. So almost all the patients had some kind of instability 8 hours before. And another study published in 1994 by Franklin has shown that of 150 cardiac arrest cases, 66% had documented instability in the 6-hour window preceding the event. So it is now customary to think that we have a window of opportunity that could be anywhere between 6 to 8 hours before the actual event, before the cardiac arrest, before we actually call in the CODA team that needs to do the resuscitation. And we could act in advance and prevent that patient from getting to a point where he needs the CODA team, to where he's actually going into cardiac arrest. So just to give you some numbers around this so we can wrap our heads around this, we know that cardiac arrest or shock occur in 0.6% of medical patients and 0.5% of surgical patients. We also know that 15 to 20% of cardiac arrest patients survive to discharge. So once we do start resuscitation, there's up to about 20% chance that that is going to be successful and the patient is going to be discharged from the hospital. So if I take this into account and calculate the numbers for a normal hospital, an average hospital with about 20,000 medical and surgical admissions, we expect about 100 codes, 100 cardiac arrests yearly. That would end up with about 83 inpatient mortality. Now, if I know that 50% or roughly 50% of those could be prevented, we are dealing with, on an average hospital, about 40 cases of mortalities in the hospital that could have been prevented. And these, of course, are huge numbers that we all as healthcare professionals and patient safety and quality professionals need to address this and need to drive this number down, just like we're doing with any other patient safety issue. And of course, this has not been something that we just found about in the last few years. The Joint Commission National Patient Safety Goals back about 10 years ago already said that one of those goals is recognition and response to change in patients' condition. And this has been coming out from the same evidence I've just showed you, and understanding that we have this potential to save patient lives. Now, we know timing is everything in the hospital with acute care. Timing of several acute care interventions have substantial impact on mortality. Just a few, for example, we know for myocardial infarction, we have to initiate percutaneous intervention as soon as possible. We're measuring 90 minutes for ST elevation, for instance, and we know that every minute counts when it comes to myocardial infarction. Similarly for starting the treatment for aspirin and beta blockers in those cases, but also in other conditions. What about emergency resuscitation? We all know, we learn about this from day one, that if a patient goes into cardiac arrest, we have to start cardiac resuscitation as soon as possible. And that could be critical in improving his outcomes. And what about stroke? We're lately seeing more and more evidence and the importance of early intervention in acute stroke. Whether it's angiography, whether it's thrombolytic therapy, we know we could reverse some of the symptoms that stroke patients are coming with to the emergency department. And lastly, sepsis, early goal-directed therapy for sepsis patients. The earlier I recognize my patient is in sepsis, the earlier I initiate therapy, the better the outcomes. So timing is everything in many, many conditions in the acute care setting. One of the most interesting studies that I want to share with you was done by Young in 2003, published in the Journal of General Internal Medicine. And what they've done is they've retrospectively looked at patients that were transferred from the floors, from the wards, into the ICU. And they looked at each one of those cases, and they determined whether it was a slow transfer or a rapid transfer to the ICU. They had a cutoff at 4 hours, so anything that happened, the patient was waiting more than 4 hours once we decided he's in ICU. If he was waiting more than 4 hours or less than 4 hours, this is how we broke up the groups in the study. And then when you look at the slow transfer versus the rapid transfer cases, you see that the slow transfer had an in-hospital mortality of 41%, while the rapid transfer had a mortality of 11%. So almost 4 times mortality rates if the patients were transferred slower into the ICU. And this goes down also to look at hospital resources. Hospital length of stay, 14 days for the slow transfer group, 9 days for the rapid transfer group. And similarly for cost, 34,000 cost per patient on the slow transfer and 21,000 for the rapid transfer. You could see the p-values are significant for a few of those. So this was a nice demonstration to show that the quicker we transfer our patients to the ICU, the quicker we can initiate treatment that is needed for those patients, the better the outcomes and lower the costs are for this hospital. And the solution has been around for a few years, or we thought it's around. We called it rapid response teams, and this was endorsed by the Joint Commission, by IHI, by the National Quality Forum. It was quickly endorsed during the early 2000 years, and it took off in many, many hospitals around the world, in Europe, in Australia, and of course in the United States. But there are problems with the evidence we're seeing with rapid response systems. And there are a couple of trials, and some of these are well known. One of those larger trials is the MERIT trial done in Australia. 23 hospitals that were randomized, some of them to continuing whatever initiations they were doing, and the other one was actually implementing a rapid response team. And they compared these two groups of hospitals and found no substantial effect on incidence of cardiac arrests, unplanned ICU admissions, or unexpected deaths between the hospitals with rapid response systems and the hospitals without. And of course, this is a large trial that has brought up a lot of question marks on rapid response systems. Brigham and Women's, the hospital I'm also working at, actually has shown another trial to show by Jeff Rothschild in 2008 that showed no evidence of improvement after implementation of the rapid response teams. And the large meta-analysis published in 2010 at the Archives of Internal Medicine has shown again that the data supporting rapid response systems are not robust, as the authors have stated. So there are a lot of question marks around rapid response systems. Now, when we look at the rapid response system, and for those of you who are not as familiar with the system, what we have basically is we have a patient, and the patient is deteriorating. We need to identify that the patient deteriorates. Once we do, we call on a rapid response team, which usually is composed of an ICU physician, an ICU nurse. They come to the bedside and they decide if the patient needs to be transferred to the ICU. If he needs to be transferred to the ICU, then they make all the arrangements to transfer that patient. So when we look at this, from the first days of rapid response systems, they were looking like this. We have an afferent limb, we have an efferent limb. The afferent limb is the event detection. This is what you see here on the right of the screen, is the event detection and response triggering, so that the rapid response team knows that there is a patient that needs their attention. The efferent limb is the planned response. So whatever the rapid response team needs to do, whether it's transfer to the ICU, whether it's some orders for medications or workup that the patient needs to do. So whatever the action they take is the efferent limb. And when we look at maybe what could be going wrong with rapid response teams and why we're not getting the results we expect, the main idea today, the main notion is that our problem is mainly in the afferent limb, in the event detection. And this is where we need to be focusing our efforts. So it's not just about not knowing what to do with the patient once the rapid response team gets to the patient bedside. They usually know what to do with the patient. The big problem is, how do we get those folks to the bedside as early as possible, and which means we need to identify our patient as deteriorating and his need for the rapid response team ahead of time. There was a nice review article in the New England Journal of Medicine that was published in 2011 that was looking at the reasons for failure to rescue. Remember that term, failure to rescue? And if you look at this is a table from the article itself, but if you look at these arrows on the left here, what I've done is I've used red arrows to show any one of those reasons that is not addressed by rapid response systems. And the blue arrows, and the red arrows are addressed by rapid response systems. So if we look at the first one, for instance, on the top, monitoring technology is used only in the intensive care unit or step-down unit. We know we're not using continuous monitoring technology on the general floors. This is something that the rapid response team will not be able to help us with, obviously. Second one, hospital ward monitoring is only intermittent vital sign measurements. As you all know, we take intermittent vital signs once every 6 hours, maybe once every 8 hours. And the nurse approaches the patient, she takes blood pressure, heart rate, respiration rate, saturation, but it's only done once every 6 or 8 hours for most of our patients on general floors. While in the ICU, our patients are continuously monitored. So again, that is not addressed by a rapid response system. And we could go on. Intervals between measurements can easily be 8 or 6 hours apart, as I've said. Regular visits by hospital ward nurse vary in frequency and duration. Visit by unit doctor may occur only once a day. So all of these, what I've highlighted in the blue arrow, are not addressed by rapid response teams. So we need to make sure we find a way to address these if we do want to have a meaningful impact on failure to rescue. And I think this diagram really shows you the essence of everything. What we see here is we see an instability growing on a patient after an acute process. As you see, the time 0 is the acute process that the patient is exposed to, and it could be the onset of sepsis, it could be the onset of internal bleeding, it could be a pulmonary emboli that just was initiated in that patient. And then we are counting time from that point 0 as instability within the patient increases. At some point, the patient goes into cardiac arrest. This is closer to the 8-hour time frame you're seeing here on the slide. Once we identify the patient is in cardiac arrest, we call in the co-team. The patient usually has about 15% of making it out from the hospital at this point. We do want to improve that 50%, which means we have to identify the patient earlier in the instability process. If we do that earlier, we could call in the rapid response team. They would have sufficient time to prevent the patient going into cardiac arrest. So the more rapid response team activations you have in your hospital and the less code teams activations you have in the hospital, you're probably doing something right in terms of identifying those patients earlier and improving their outcomes considerably. So what do we need to track? Now that we understand that we need to track continuously vital signs, we can't just do with point estimates. What is our best choice for what we need to be tracking? And again, this diagram goes back to the early physiology days that we all go through as nurses and physicians. We've seen this in the past. So I'll briefly share with you one of the points I want to make. If we look, this is again our patient, and there's an onset of a potentially mortal event occurring on the left here, and as we move to the right, time is moving, and this is the window of opportunity we want to make sure we don't miss. So if we look at one of the things we are using quite often, and that's the saturation, the O2 saturation, the oxygen saturation, we see that the oxygen saturation remains normal, remains high for a very long period after the onset of the potentially mortal event. It actually starts going down, as you see here, the first SpO2 threshold warning many hours after the initiation of the event. And that could be too late, because once it starts going down, it drops very quickly. The patient will go into cardiac arrest. So we need an earlier sign to look at. And there are other options. One of them is arterial carbon dioxide, what we see in capnography. We see this going down from the early stages of the onset of potential event, and respiration rate, which goes up, again, from the very early stages of the onset of the potential mortal event. So these would be two good criteria, two good vital signs for us to track if we do want to identify early on that the patient is deteriorating. What's the problem with respiration rate? Any one of you who's worked in a clinical environment knows this. We call it the missing vital signs syndrome. Why is it called the missing vital signs syndrome? Because many times it's missing. We don't see it recorded on the medical record. There's been this study published in 2009 by Chen and colleagues in resuscitation showing that respiration rate in almost 25 to 30% of patients was missing from the charts. And we know why this is happening. Respiration rate is difficult to measure. We can't just put a blood pressure cuff or an SpO2 device on the finger to get that reading. We need to actually manually count the patient's respiration rate. And the patient can actually affect that respiration rate. The patient can be breathing quicker because he wants to, or slower because he wants to. So it's not like measuring blood pressure or heart rate where the patient has no control over that, of course, and there's a good chance that what we're capturing is the real status of the patient. So we have a huge problem with capturing respiration rate and doing a good job in actually measuring it. So let me maybe stop here before we go into the solutions and see if there's any questions so far from the listeners.
Thank you, Dr. Zimlichman. We have one question so far, and we just remind the remainder of the participants, if you would like to, if you have any questions, please type them into the chat or question box provided. So the first question is from Nafisa Idou, and she's from Nigeria. Her question stands as follows. Adverse events cause large numbers of deaths in hospitals, while with an earlier intervention, the situation would have been different. So her question is, how do we improve aggressive intervention to save patients?
Can you repeat the last sentence?
Yes. So she's asking, how do we improve aggressive intervention to save patients? Patients.
So that is part of what I'll be talking about in the next part of this webinar. But as far as what I've stated so far, what we definitely need to be doing much better is better monitoring of our patients. Because on general floors and around the world, this is a fact, we are not seeing the patients enough. The nurse are seeing the patients maybe once per shift. The doctor is seeing the patient once per day. And for some of these acute events that happen, we need to be tracking the patients continuously. And it goes to almost everything that we could think about as adverse events, even falls. So we need some types of tools that will help us. And I'll be walking us right now in the next 20-25 minutes through some of those solutions and the evidence that we have that shows that it's already working. So if there aren't any further questions, let me jump ahead. And of course, there'll be an opportunity at the end to ask more questions.
We do have one more question. So okay. If we can, that's coming from Leonard Kabongo. And he's asking, how can you improve on basic vital signs in a low resource setting hospital where the PaCO2 is rarely measured since there is most important vital sign?
Right. So the problem with capnography is that, first of all, we don't have it in every setting. The other problem is that it's not very comfortable for the patient to use, especially on the general floors. So capnography, for those of you who are not aware, are tongues that actually go into your nostrils, your nose nostrils, and they need to stay there. And so the patient is actually not very comfortable with that. It's a good solution when you're in the ICU. It's a good solution where you're in the operating room or post-operating room, but not on the general floor where many of these patients want to move around. They don't want to be tied down with wires to their bed. So I agree that's not a good solution. There are solutions that fits a low-income environment. And I'll mention one of those implementations that was done in the UK in a few slides.
Thank you, Dr. Zimlichman. We have one more question. I think we can take that just before we break for the second part of your webinar. So the question is from Divine Akpan, and he is asking, could there be a significant change in the result in the merit study as a result of already adequate response system being in place in the hospitals where the study was conducted?
Right, right. So, of course, it's one of the questions that we're always asking ourselves. What was the baseline and how good the baseline was? And I could tell you, rapid response teams do work if you get the rapid response team to the patient side in the right time. And this is something that's a consensus today. We do understand that we need to have more efforts done on recognizing early on that the patient needs to have the team approach him. And that is the major problem. Of course, when you go to Australia, Australia has always been leading in these regards. They've really carried the torch in both rapid response interventions and early recognition. So that could be some of the reasons why control hospitals in Australia were actually doing quite well. But the evidence we're seeing on rapid response systems are not just from Australia, they're from the US. There are numerous studies that actually have shown this. I've only shared a few here. But do have that consensus saying we need to do a better job in recognizing that the patient is in need for the rapid response team. And there's a whole full literature around this, and how do you make this work, and how do you make better response teams and response systems, and the communication piece between the nurses on the floors and the rapid response team is something that has been studied a lot. Of course, we don't have time to go into all of that here, but definitely there's a lot of literature that supports how do we make rapid response systems work better.
Thank you, Dr. Zimlichman. We will take the remainder of the questions at the end of the session.
Great. So I'll jump right ahead. And so what would be the approach to preventing ICU transfer delays, as we're now homing in ICU transfer delay as our main issue in preventable death? So one way to do this, and I'm sure that most of you have heard of this, are risk scoring systems. And they're based on physiological data. I'll give you an example in a short while. Medical history, demographics, and they estimate the risk of deterioration. Usually they're based on evidence and trials from other studies that were done in the past. An example from something that is emerging from the UK is the modified early warning score. There's also the national early warning score and the original early warning score. So there are many early warning scores that came out from the UK. There are others like the Intensive Care Society classification, the Rothman Index, and many others. And the other approach to this would be surveillance monitoring systems. So continuous monitoring for all our patients at a medical and surgical setting. That would be another way to identify ahead of time that the patient is deteriorating, and we'll go through some of those examples. So when we talk about risk scoring systems, of course, there's so much literature around this, but I chose one here to describe some of the problems we're having. This was published in 2007, was a systemic review in intensive care medicine of 36 patients describing 25 distinct scoring systems. There are many, many of them out there. They found 25, and they found that no system met the requirements for a level 1 clinical decision rule, meaning that a rule is widely validated to change clinical behavior and improve outcomes. And there's a wide variety of published systems, lack of statistically sound validation of any particular system, and systems had low sensitivity and positive predictive value. So this huge numbers of scoring systems that we see out there with about very little evidence on most of them is one of the issues. And if you do want to start something like this in your own hospital, you're going to need to read the literature quite well and find out which ones have more evidence than others. And an example of one use of this is an electronic automated advisory vital signs monitoring in a general hospital. You could see it's a monitor that actually, if we look up close at the screen, apart from the traditional vital signs of blood pressure and SpO2 and temperature, what we also have is the modified early warning score. You see it up here on the monitor with a score of 8. And there are systems today that actually track those early warning scores continuously, or as far as they have any vital signs inputted into the system. And you could attach that to an alerting system that says when the early warning score crosses a certain threshold, I want to know about this, I want an alarm to go off. So it is something that is used and is embraced by technology, and we're seeing more and more use of these. Again, the question is, which score will we be using? Which score is better than the other? And there are no very clear evidence on that currently, but certainly we have more experience with some of those than others. This is a very interesting study, and I do want us to put about 5 minutes on describing whatever happened here. This is done by Paul Schmidt in the UK and published at the BMJ Quality and Safety just last year. And this is an electronic physiological surveillance system. And what they've done is it's a retrospective observational study in 2 large acute general hospitals in England. And they've used iPads only that the nurses have actually carried around to input the vital signs, and those were embedded into the EMR. The iPads calculated the patient's early warning score, and there was a decision support to the nurse what to do at that specific time. So while the nurse was inputting the vital signs into the iPad or into the tablet, they got a message saying when the next set of vital signs is due, whether care should be escalated to senior staff, and what the required speed of the response needs to be. So here's an example, and this is very easy to do. Actually, you don't need a technology to do this. You could actually even do this without a technology. So this is the modified early warning score, and you see here the respiration rate, oxygen saturation, temperature, and so on, goes all the way to urine measurement. And whatever we see on the respiration rates, we get a score that is assigned to that respiration rate measurement. So if the respiration rate was 9 to 20, the score is 0, and so on and so on, and this goes on for all the other vital signs. Once we have all those and we sum up the score, then we know what we need to do, and this is the action plan that is stemming out from the scores. So if we have any vital sign in the pink zone, or a total score of 8 or more, any vital sign in the pink zone, notice the pink zones on the table, both on the left and the right, then we need to, at this case, dial the emergency number, state medical emergency team, and stay with the patient. So we have a clear decision support tool that tells us what we need to do if we identify that the patient is probably deteriorating. And this goes on, we won't go through everything, but if any vital sign is in the orange zone or the total score is 6 to 7, then this is what we need to do, and so on and so on. But you could see how this is a very structured approach to trying to make sure we're not missing any early warning score, and we are initiating the proper interventions and getting the right people to the bedside. This was done on a tablet, as I've said, but it could also be done with paper and pencil. So this is a screenshot of the tablet they were using, and as you could see, they were keying in the pulse. This was 112. This went into the electronic medical record, so it saved them some time. They didn't have to key it again on the computer. This is an example of all the vital signs that were keyed in, and you could see the early warning score on the right, which color is designated, and of course the nurses need to act according to what we've seen in the former slide, and the total early warning score is also stated here. The other thing that the nurse could see in this trial is, for instance, the lab results, as you could see here, for this patient, so she could review that clearly. Of course, if you have a good EMR, then this might be redundant. But still, this provides a very nice tool to just input your vital signs and get a decision support in real time on what needs to be done. So what happened after they initiated this? And this is a nice observation they've made here. This is basically a control chart. I'm sure most of you are used to seeing control charts. And what we're seeing here is the mortality. This is season adjusted, so we're not seeing any differences and higher mortalities in the winter as we expect to see. And you see the mortality as the white circles, and what we're seeing in the as the darker line, the black line, are the actual observations done by the nurses using this system. And you could see this was all initiated really in November of 2008, and you could see that starting the initiation, when the observations have gone up considerably to the new status quo, in the same time mortality has gone down. You could see this very nicely on the control chart. Again, this is a retrospective study, so it's not as powerful as a prospective study and a controlled prospective study, but it is very nice evidence that shows us that something has been going on. Mortality was affected by the fact that we're using the system. So this was in one hospital, and this is in the second hospital, again showing very similar results, even more attenuated here, where mortality is going down while the observations go up. And very nice evidence to show that this intervention had an effect. And again, they used technology, but you could do this even without technology with proper decision support. It could be posters, it could be pocket books that tell you what you need to be doing. This is something that's pretty easy to implement. So what are current continuous monitoring modalities? So we said one way would be using early warning scores, but even if we do use early warning scores on point estimates of vital signs, we have some problems. And I just want to make sure that this is a message that goes through. If we're saying that our window of opportunity is 6 to 8 hours ahead of deterioration, and we're doing point vital sign estimations once every 8 hours for our patients on general floors, we could miss that window completely. So if a nurse takes vital signs in 0.0, then the patient starts deteriorating. By the next time the nurse returns to that patient in time 0 plus 8, that patient might already be dead. We could have missed completely our 6 to 8 hour window frame of opportunity. So this means we have to receive vital signs, we have to record vital signs much more than what we're currently doing. Could be manually once every hour, it would probably solve the problem, but we don't have the nursing power to actually do this once every hour. So we need some type of technology that is adjusted for general floors. It's not the same technology that we use in the ICU, and that technology would provide us with continuous monitoring. So let's see what's out there. The traditional one, we've been using it for many, many years, is telemetry. The problem with telemetry that it was designed to monitor patients for cardiac arrhythmias, yet we use it for worrisome patients, and we all know this. We have a patient on the floor, and it doesn't look right to us. We think maybe something is going on, he might be deteriorating, he's not responding well, his vital signs are starting to be off. What do we do many times? We put him on telemetry. Is that the good response? I would say no, because telemetry would alert us when the patient goes into cardiac arrest. That would be too late. Again, we want to capture it before. So telemetry is not the right tool, not the right device to use to call on the rapid response team. It's the right device to call on code team. And there are emerging ones. We could use continuous saturation. We could use continuous end-tidal CO2, as I've mentioned before. And we could use continuous respiration rate. So let's see what we have out there. One example published in 2008, Archives of Internal Medicine, has shown continuous monitoring of a step-down unit. This is not a general unit, a step-down unit using an integrated monitoring system. They had continuous monitoring for 3-lead ECG, respiration rate, saturation, blood pressure every 2 hours. And you see the numbers of patients here. Probably this would not work on a general floor setting, but again, in a step-down unit, this is possible. First of all, we see what was the criteria for calling on the rapid response team. You could see that the number one criteria was high respiration rate. 22% of all rapid response team calls was because of a high respiration rate. 18% were because of a low SpO2, and then 16% were because of low systolic blood pressure. Lastly, 15% because of low respiration rate. So these are the most common events to call on the team. Now, out of 83 patients who reached criteria for rapid response team activation, only in 10 the team was actually activated. And serious instability was found to be a multi-parameter. So what we're seeing here, these are all the patients that we call the rapid response team for, and you could see that some of them had serious instability, some of them had mild instability. If we look at the mean heart rate values and the mean respiration rate values, we would see that all of the patients with the serious instability had both high heart rate and high respiration rate. If it was only high respiration rate, many times it was called on as a mild instability. Basically, what this tells us is that we need to be tracking both heart rate and respiration rate to really find out with which patients are in serious instability This was a very important observation. This is another one. I'll go through this very quickly. Pulse oximetry surveillance, and what they've shown here, again, you can see it on the right, that transfers to ICU on the intervention, after the intervention, have gone down per 1,000 patient days. You could see before the intervention, the ICU transfers from the floors, and after the intervention. The problem with this study was that this was using continuous SpO2, which means that the SpO2 sensor had to stay on the patient's finger continuously throughout his hospitalization. And again, the clinicians here would know that this might be a problem for patients. Many times it falls off, and then you get a false alert. Patients take it out, they don't place it back. So it is an issue in the general floor setting. So surveillance monitoring systems of low-risk hospitalized patients, which is what we're focusing on right now, had to be, if we were to think now, what is the perfect solution, the perfect technology to monitor those patients? First of all, we mentioned it has to be continuous. The point estimations just won't do it. It has to be easy to use for the staff, because when we talk about the general floors, we're talking about a nurse-to-patient ratio of 1 to 8, maybe even more during the night. So if the nurses have to go around and attach these wires and patches around patients, that could pose a problem. It has to place as little limitation on the patient as possible, because these patients want to move around, they want to take their own shower, they want to sit in the cafeteria with family members. Many of them are active and they don't want to be tied down to bed. Most importantly, there has to be low false positive rate, which means we want to prevent alert fatigue. And you're familiar with this term, and this really what it says is that many times when we have false alerts and we rush to the patient's bedside only to find out that one of the leads of the monitor fell off, or the SpO2 sensor fell off the finger, and the next time we'll be called with an alert to the system, we might not be running, because we will figure out, well, again, something technical is going on. This is called alert fatigue, and this is something that we want to address, of course, especially in the general floors, even more than in the ICU. It has to be integrated monitoring. It has to be integrated with the EMR so that the information flows into the EMR, and in the future, we will be using that data together with lab data, together with clinical data, to make even better predictions. And at the end of the day, it has to be cost effective, because if it isn't, in the current reality of healthcare, we just won't have these technologies play a major part. So I do want to talk with you about this last approach, which really is trying to design a monitoring device that fits general floors. This was built with all of these in mind to make sure that we have a technology that fits general floors, and again, that we're not taking technology that was built for the ICU and just using it on the general floor. So this is a device, and what you see here is a sensor that is put under the mattress of the patient on the bed in the hospital. That sensor is very, very sensitive in measuring heart rate, respiration rate, and movement. You'll see some of the data in a second, but it does use sophisticated mathematical modeling algorithms to alert for both clinical deterioration using respiration rate and heart rate, as I've seen in that former trial. These are probably the most important vital signs we need to focus on, but it also has some functionality towards preventing pressure ulcers by identifying how much the patient is moving in bed and preventing patient falls. I will not be talking about these two other applications, but we'll be focusing on the clinical deterioration. So I was part of a research team. We published this in 2010, doing the validation of the system. We started with validation in a sleep lab and then in an ICU setting. And basically what we found was that this was very, very accurate. And you could see some of the numbers here. I'm not going to go into too many details here, but the paper is out there. You could look at all the details. But the most important thing to note is that we found that using this device to measure respiration rate was the most accurate respiration rate monitor that exists today outside of sleep labs. Of course, within a sleep lab, you have more accurate technologies, but outside of a sleep lab, as I said before, we have a huge problem with measuring respiration rate, and this was found to be a good tool, and this was, of course, approved by the FDA, of course, to measure respiration rate. So that was good news for us clinicians and patient safety, professionals, because we do have a way to measure respiration rate finally, as we all understand how important that is. Then I headed another trial, which was the first clinical implementation, 2 hospitals, and what we've done is we've used the devices, but they were not active. They were just recording, they were not alerting, they were in silent mode, just to figure out retrospectively if the patients that have deteriorated, were they discovered by the device ahead of time. And I'll quickly run through these numbers. Out of about 10 patients that had major clinical events, they either died or were transferred to the ICU. This was the sensitivity and specificity and positive predictive value and negative predictive value of this technology in identifying which patients did indeed deteriorated and either died or needed an ICU. And you could see when we look at heart rate and respiration rate, the specificity is 94%, which means that if a positive predictive value of 50%, meaning that when you do get an alert, there's a 50% chance that this patient is going to deteriorate or either die in the next 24 hours, which is, of course, a very high figure for any monitoring technology. The negative predictive value of 95% basically tells us that if the monitor is silent, there's a 95% chance that nothing is going on, which is, again, pretty good for us to trust this technology in monitoring our patients. We've used trend alerts also, which is what the technology is actually today, and we found that to be slightly higher with a 98% negative predictive value and 54% positive predictive value. So I want to describe to you the full implementation of interventional trial that was done in a Los Angeles hospital. This was published in the American Journal of Medicine in 2014. It's a 33-bed medical surgical unit. There was a wireless connected central nurse station and pagers for nurses, so every nurse had a pager for her patients. And there's, as you see here on this picture, there was this central nursing station that had all the patients in the ward monitored through this device. This is the bedside monitor you see on the picture on the right. The primary objectives were to look at transfer to intensive care units, length of stay. Secondary outcomes were code blue events and pressure ulcers, and also return on investment, which I won't be sharing with you here because of lack of time. So what were the study outcomes? This was the control unit, this was the intervention unit, and for each one of those units we had a baseline before implementation and then after implementation as we were tracking our outcomes. One thing to note is the length of stay in the medical surgical units has gone down from 4 to 3.6, which was statistically significant, while you see in the control units, the reduction in length of stay was not statistically significant. It wasn't significant. So we're seeing an almost 0.4 drop in length of stay for all our patients on average in the medical surgical units by using this technology. This was quite interesting for us to find out. Second point I want to draw your attention to is that are the days for ICU transfer. So all patients from those floors that were transferred to the ICU, we call this ICU utilization. How much ICU resources did we use? Look at this very, very interesting figure. The baseline and intervention period, this has gone down almost 50%. So we're seeing 50% less ICU utilization in the post period compared to the pre-period before the implementation. The other thing I want to note is the decrease in the code blue events, in the cardiac arrest events. These have gone down from 6.3 per 1,000 patients to 0.9, statistically significant. And this was a big surprise for us because the study wasn't powered to look at code blue events, but we did find this very significant drop in code blue events. What we're thinking happened here is that these monitoring technologies, again, have identified the patients ahead of time. Still, the patients were transferred to ICU, but they were transferred to the ICU earlier on in the deterioration process. Then their stay in the ICU was shorter because they didn't need 4 or 5 days. After 2 days, they were discharged back to the medical surgical unit. That also brought down the cardiac arrest, again, because of the early detection. So what we're seeing here is real data, true data, after some of the theories that we were just running through in this lecture, and we're seeing this really happening when you do apply continuous monitoring. Another figure I want to share with you is the number of alerts that went on in that unit. Because of course, if this device alerts the staff all the time, and you'll see staff running to the patient's bedside many, many times, then we have a problem. We can't really, this won't do for a general surgical environment. So what you see here is for a fraction of the patients, we've done this sub-study where we looked at the number of alerts. We came to an average number of alerts per 12-hour shifts for all the nurses on the floor to 12 alerts per shift. If you look per nurse, assuming six nurses on the shift, this means 2 alerts per shift for a nurse. When we asked the nurse in this subset study whether this was a false alert or a true alert, 0.6 alerts were deemed as false alerts, which means 1.4 were true alerts. So basically what we're seeing here is that each nurse would see 2 alerts with this type of technology per shift, one of them on average being a false alert, one of them being a true alert, meaning that the patient indeed is deteriorating, which is similar to the 50% positive predictive value we've seen in the earlier trials. If you compare this to any other technology, look at the number of alerts per 100 hours that we get on any other technology. This is again a literature review we published, and you could see these go all the way up to about 700 alerts per 100 recording hours. This type of technology again has 2.2 alerts per 100 hours of recording. Again, a different ball game completely, and it is something, again, as we're seeing, what are the technology for monitoring that will be used in the general floors? I think we're starting to see that first applications that were built specifically for general floors, having much less alerts and being much more specific. And we're coming towards the end. I'll finish with this. This is an editorial piece that I published with David Bates in BMJ Quality and Safety in 2014. And we called it Finding Patients Before They Crash, the next major opportunity to improve patient care. And we think that there's a coming together of 4 major trends or innovations that we think promise substantial improvements to patient outcomes. One of them is the uniform use of electronic health records in hospitals, and the data is available to us to use. The other one is major advances in physiological sensor development, like the example I gave you with the company called EarlySense, and there are more coming out almost every month now, and this is something we'll be seeing much more of. Then the rapid adoption of mobile technology. We'll be using mobile technology, the nurses, the physicians will be using mobile technologies to make this data and alerts much more available to us. And then ability to perform analytics in the background, what we call big data, to provide decision support at the point of care. So it's not just looking again at all these vital signs that are coming in and bombarding us, and the nurse then has to make a choice whether they need to call the rapid response team or not, is something going on or not. We'll be using, we've seen this with the early warning scores, we'll be using more of that. They will be much more accurate as we move forward in time, looking at labs, looking at vital signs, clinical history, to know what the patient is going through and provide us with better analytics. So what's the take-home message? First of all, ICU transfer delays are a preventable adverse event that must be addressed. I hope I convinced you with that. Then early recognition of instability with timely intervention could improve patient outcomes. It could be the missing link to making rapid response systems effective, as I've shown. Respiration rate and heart rate are independent predictors of clinical deterioration. There are other studies that show that. I didn't have time to go into this today. And respiration rate, as we've seen, is the most common trigger for rapid response team activation, so it is a very important tool for us to monitor. Spot vital signs checks cannot replace continuous monitoring event for low-risk settings. We've talked about the window of opportunity and why we need that continuous monitoring. And finally, technology solutions are emerging that allow to continuously monitor patients at any hospital setting, adjusting to the needs of the specific environment. And again, we've seen one example. There are others that are taking shape right now, and more studies that will be coming out in the immediate future. So with that, I'll thank you very much, and I'll open up for maybe the last 5 minutes for more questions.
Thank you, Dr. Zimlichman. Thank you for this very practical and very useful and informative presentation. We do have indeed a number of questions, and we will start with them straight away so we can address as many as we possibly can. The first one is from Akio Hirata from Japan, and he's asking, is there any attempt to use quality indicator, so to speak, so we have a common quality improvement related rapid response system?
Well, if the question is specifically for quality indicators for rapid response systems, of course, one of the things that we have in a rapid response system, again, if we do this by the book, is we need an audit system that actually goes through the numbers and checks this out. Most of the places use this regardless. For all of our code blue data, we go through this data, we find out how many patients have gone into cardiac arrest. We could track that. It is a good metric to track on a hospital level your number of cardiac arrests or the number of code team activations. And as I've said before, we're starting to understand now that in a hospital where we're seeing number of code blue activations go down, while we see the number of rapid response team activations go up, this is what we want to be able to show, that we're recognizing patients' deterioration ahead of time. By activating the rapid response team, we actually prevent the code activation later on, where again our chances of survival are much lower. So this whole thing now, we've been doing this for a couple of years now, but I think we're understanding how important it is right now to measure these rates and then do audits on all of these cases and identify whether it's with a root cause analysis technique. On every one of these cases, we have identified that ahead of time? Why wasn't the rapid response team called ahead of time? I would say any cardiac arrest patient needs to be studied in this fashion. I would, I think I would have a root cause analysis done on any cardiac arrest activation to understand whether this could have been handled differently.
Thank you, Dr. Zimlichman. The next question is from Samia Fadul, and there is a similar question from Ximena Hernandez. And they're asking, can the rapid response team be effective in developing countries with limited human resources and technology?
Right. I mean, the rapid response team basically is manpower. It's personnel. You need the right people to be available. In some countries that I've seen this work, it's sometimes based on the same personnel you already have working. And it could be that you might not have a rapid response team during the night. The first thing to do, which is very easy usually, is to have your rapid response team work during the day hours when you have your full team usually in the hospital. And then you designate one physician in the ICU and one nurse in the ICU to be the staff that would respond. They carry pagers or phones around, and they could be called to the bedside of a patient that we think needs their attention. So starting with that is very easy. Everybody almost can do this if you have the right human resources. Doing this during the night and having an extra personnel during the night that would be able to respond is sometimes more difficult to do in developing countries, but I would say to every one of us, we could start doing this for the day hours even tomorrow. If we have, obviously, we need to have the right expertise in our professional team, but if we do have that, then it shouldn't be any issues to start a rapid response team at least during the day hours.
Thank you, Dr. Zimlichman. The next question is from Inas, and he's asking, these high technology devices are not available in the Middle East countries, even in richer countries. So what would be your advice in trying and implement what you were talking in this webinar?
So it's a very good question, of course. If we don't have this type of technology that allows us to continuously monitor patients, I think we need to be aware of the problem of having point vital sign estimations done every 6 to 8 hours. If it's possible, sometimes we have a problem with technology, but we have more resources on the manpower side. It's possible to have point vital signs done every 4 hours. I think that makes a huge difference. And it could be performed in many locations. So that's one thing that I think is imperative to understand. The second thing is, what do you do once you take the vital signs? How do you appreciate if your patient is deteriorating? And I've shared with you that trial in the UK where they were using the modified early warning score. And again, the modified early warning score is out there. Everybody could use it. It's free to use. You don't need to pay anything for this. And you don't even have to have the tablets that I've shown you that they were using in the UK. You have some kind of action table or action cards in your pockets, or something that is attached to your tag, your hospital tag, your name tag, that says if you see vital signs in this or that threshold, you need to call in the rapid response team. So what are your actions that need to happen once you take vital signs? Many nurses are afraid to call on a physician or a team because you think something is wrong. And then when the physician comes over and says, well, everything seems in order, why did you call me? That nurse would be intimidated to activate the team the next time. But if we provide her with clear decision support of when we need to activate the team, then she would act by that decision support. And you know, you've seen those results, remarkable results from the UK study. Even if you take away the tablets and you use paper and pencil, I think you'll be able to achieve very similar results.
Thank you, Dr. Zimlichman. And we will finish the Q&A session with the question from Charles Payne. And he's thanking you for this excellent presentation. And his question stands as follows. In New South Wales, we introduced a comprehensive system 6 years ago in 225 hospitals, which has been associated with a reduction of 42% in unexpected cardiac arrest rate. It is called the Between the Flags system. Continuous monitoring is the next evolution of such system in advanced health system. Do you have any advice about how to implement such a system at scale, sustainably across health system in less developed health systems?
Right. So as I've said, you know, technology, obviously, when you want to implement technology across your general settings, usually, you know, it carries its costs. It's not easy to implement on large scales. I do think that this is what we're going to be seeing as the norm a couple of years down the road from now. But we are in this phase where, you know, we're quite hesitant to introduce new technologies across a large number of beds. And I would say that if we can't have continuous monitoring technologies, try to see whether you could have the point estimates be done closer together. Again, it's a manpower issue. We're limited in numbers of nurses, and the nurses can't just go around to take vital signs. But we could be using other forms of healthcare professionals. It could be nursing aides. It could be lower paying professionals who take the vital signs and then use a very structured approach. Again, you don't need to be an ICU nurse to key in those numbers and understand, according to an early warning score, that the patient might be deteriorating. So even the nurse aide could do it, and you could utilize this type of professionals to have your vital signs be measured closer together rather than further apart. Again, remember all the time we have that 6 to 8 hour window of opportunity. And if we do this every 8 hours, which most of the times that's what we do, if we do this every 8 hours or even every 6 hours, we're in the danger of missing that window of opportunity completely in between our vital sign checks. So if you take this down to 4 hours, I think you'll be able to improve your results ahead of any continuous monitoring technology. But again, I think continuous monitoring will become the norm. We'll see these technologies take form. They'll be cheaper to use. I haven't shown here the return on investment on such a technology, which really we've done to show the administrators and the financial folks that we need to invest in this type of technology. There's a paper that we published in Clinical Care Medicine Journal that if those of you are interested, you could find this out. That was published in 2014, which clearly shows the return on investment on continuous monitoring technology. If you need to use that with your financial folks to make the case, use it. That's exactly the reason why we've created this. It was important for us to show that continuous monitoring technology does need to take hold as we move forward.
Thank you, Dr. Zimlichman. We will ask you to share the link to the paper, and we will include it with the recording of this webinar for our participants to review. I would like to thank you for this fantastic presentation and for sharing, for contributing your expertise on this subject matter and for sharing your knowledge about the continuous monitoring. We would like to thank our audience as well for participating and asking so many questions, and we hope to see you all again. Thank you again, Dr. Zimlichman.
Thank you very much. Good luck, everyone, with this.